This lesson is going to be about acute coronary syndrome. And while it is possible to have the diagnosis NSTEMI secondary to something other than acute thrombosis, we are not going to consider that. We're going to cover the different acute coronary syndromes, unstable angina, NSTEMI, and STEMI, and how you separate them clinically. Talk about subendocardial versus transmural infarcts. And most of the lesson is going to be dedicated to walking through the evolution of a myocardial infarction that does not get revascularized. This is the natural story told by the cells that informs what the histology and the gross anatomy looks like. This is an exercise you will be tested on, but it is also an exercise in demonstrating how medicine is modular. What you'll see is what you learned in inflammation and neoplasia, necrosis and wound healing, is the exact same thing that happens here, only because it's the heart and not the skin, complications are a little different. So let's start off by defining the acute coronary syndromes. And for the subject of this lesson, we are going to assume thrombosis is the cause. Plaque rupture, thrombosis, resulting in acute luminal change means supply ischemia. You are going to differentiate the different acute coronary syndromes clinically based on the pattern of pain, chest pain, the biomarkers, and TROPS is short for troponins, whether or not there are ST segment elevations, and you'll be able to link that to percent occlusion and the presence or absence of an actual infarct. Unstable angina, NSTEMI, a non-ST segment elevation myocardial infarction, and versus a STEMI, ST segment elevation myocardial infarction. In chronic coronary artery disease, stable angina was defined by the exact same amount of exertion, came up with the exact same amount of pain. Now the plaque can progressively get worse, so the patient may be able to do less and less, but that's a gradual process that they likely won't notice. Unstable angina is defined by a significant and rapid change in exertional capability. Can't go as far without getting the same symptoms. And if you do go as far, the symptoms are worse. That is going to be summarized by worsening on the board. Even though there's no infarction, so there are no troponin elevations and no ST segment elevations, unstable angina isn't a progressive worsening of stable angina. It is an unstable plaque that has ruptured and thrombosed. It just hasn't occluded enough to provoke an infarction. But because it's already ruptured and thrombosed, it can do it again. You can link unstable angina to simply greater than 70%. It's a critical stenosis. But it has occluded enough to make worsening symptoms. This person needs a cath, but not emergently. But not electively either. They need to have it soon. Compare that to STEMI, where there is 100% an infarct because there is 100% occlusion. No matter how little myocardial oxygen demand there is, tissue distal to the obstruction will die. That is defined by ST segment elevation. The pain occurs at rest. And here's the thing about a STEMI. The biomarkers, the troponins, at the time of diagnosis may be negative, but they will turn positive. You can find evidence of the transmural infarct with ST segment elevation prior to elevation of biomarkers. And so to put negative or positive here is misleading. You could catch it very early and they'll be negative. They will go up and continue to go up even if you fix it, because they take time to rise. We'll talk about that at the very end. NSTEMI, there is an infarct. The pain occurs at rest. The difference is it's not 100%. And usually to cause an end-STEMI, there is a pretty good occlusion, but it's not complete. And not being complete means no ST segment elevations, but diagnosed by the troponins being positive. We'll talk a lot more about management in the next lesson and why these are different. But mainly STEMI goes to cath immediately. These other two can be managed medically and then cath later. Transmural versus subendocardial infarction. We learned from that coronary artery lesson in Electricity 1 about the arrangement of the endomyo and epicardium. The endocardium and its connective tissue lines the heart chamber, and for this discussion, the supply of oxygen is blue. So the arteries will be blue because the myocardium is red. Running in the epicardial fat are the epicardial branches of the coronary arteries. These will give rise to transmural arteries that penetrate the myocardium and then give rise to arterioles, which then give rise to capillaries. The significance of this is that the blood must flow from the epicardium towards the endocardium, which means that the subendocardial myocardium these guys is a watershed area. It means that if there is decreased perfusion through these transmural arteries, penetrating arteries, the myocardium that will always be affected first are the subendocardial myocardium. In a partial occlusion, not complete, of an artery that feeds this, the furthest of these transmural arteries will be affected the most, but always the subendocardium suffers. And a total occlusion, everyone suffers. So what that looks like then is if there is an incomplete occlusion, there will be the endocardium, but then some amount of subendocardial necrosis. This myocardium is unaffected. This is a subendocardial infarct. If there is a complete occlusion, the whole wall will undergo necrosis. The whole wall means transmural. When a thrombosis claims 100% of the lumen, you're going to get a transmural infarct. The whole thing that will undergo ischemia and infarction. This is what gives you the ST segment elevation. An incomplete occlusion or any other reason for decreased flow will give you a subendocardial defect. It won't show you ST segments, but both have necrosis, so both will show you troponins eventually. This is a look at the microcirculation. I'm going to refer back to this as we fill in this chart, but I also want to do this on a macroscopic scale. This is a cross-section of a ventricle. The lumen is in the middle. If you have global hypotension, no diseased vessels, equal poor perfusion through all coronary arteries, the region that's going to be the most affected is going to be the subendocardium. And since it's global hypotension, not diseased arteries, it's going to be all arteries equally. Rest of the myocardium is okay. If there is a particular territory that's affected, that is an artery thrombosis, but it is an incomplete occlusion, the subendocardium dies first, whereas the remainder of that vascular territory remains intact. Of course, everything else is fine too. This is an incomplete occlusion of a single coronary artery, or it might be revascularization effect because these die first. And finally, if there is transmural defect, complete occlusion, a STEMI, the entire territory is infarcted and dies. The remaining myocardium is okay. And just for completeness, I won't refer back to this one again, in chronic coronary artery disease, it's a little different. You can see these micro infarcts all over the place, and they're not necessarily subendocardial, which makes this description very frustrating. So all I want you to do is think global hypotension, also subendocardium, incomplete thrombosis, limited subendocardium, complete thrombosis, transmural infarct, the whole thing is infarcted. And forget about this one. Okay, the next thing we're going to do is walk through in tabular form what happens to the heart, the myocardium, when a vessel suffers 100% thrombosis and is not revascularized. The interesting thing about medical science is that this can be overwhelming, except if you identify how modular cellular responses are. In inflammation and neoplasia, you learned about necrosis, early reversible, late reversible, irreversible. You learned about wound healing. Incision is made, debris, bacteria enter like clots. Phase 1, neutrophils arrive first. Gobble the baddies die in place, so macrophages can come in and clear the field. Phase 2, fibroblasts make granulation tissue so that the keratinocytes can receive blood to proliferate and close the wound. And phase 4, maturation, the scar is turned into acellular tensile strength by reversing the shape of the collagen. Neutrophils first, macrophages, fibroblasts. Myocardial infarction is the same thing, except instead of an incision, there's an infarction. And instead of pathogens, there's necrotic myocytes. So what we're going to do is walk through the story of a myocardial infarction that is not reperfused, link it to what you already know about necrosis and wound healing. Use that information to anticipate the histology, what cells will be present. Use that to anticipate what the gross anatomical structure will look like. And the only thing that's different and you cannot predict is the complications based on time. So, here we go. Time from thrombosis. What phase we're in. Necrosis or wound healing. What cells will be present on histology slide? If they died and you took a sample, what would the infarct zone look like? The gross anatomic appearance? If they died, what would they look like before you take a slice and put it under the scope? And based on that, what are the complications of that period? An artery thrombosis, 100% occlusion, no blood flow. In the first 4 hours, myocytes are deprived of oxygen and glucose. This is the phase of early reversible and late reversible necrosis. These cells can be saved. If you revascularize within 4 hours of thrombosis, you reverse the necrosis, they do not die. And so if the person were to die in the first 4 hours from thrombosis, the histology would appear completely normal. On light microscopy, you can't see this. The gross, because the histology is normal, will be completely normal. The complications, however, are either cardiogenic shock or arrhythmia. Cardiogenic shock will happen not because myocytes are dead, because they're still alive, but because dead things don't move and stunned myocardium acts like it's dead. So if you have a huge territory taken down, thrombosis of the left anterior descending, you may have a stunned myocardium that won't contract, thus cardiogenic shock. Arrhythmia is easy to explain. The subendocardial myocardium contains pacemakers. These are now ischemic and cannot repolarize. They act funny, Purkinje's take over. More importantly, non-pacemaker myocytes are all through the ventricle, and they need oxygen to make ATP to run the sodium-potassium ATPase in order for potassium to leak out. If they don't have it, potassium doesn't leak out, and the potential doesn't go towards the equilibrium potential for potassium, they depolarize. So depolarizing ischemic tissue leads to arrhythmias that kill people. The number one cause of death in the first 24 hours of a myocardial infarction is arrhythmia. And also notice, this can happen while everyone's still alive. So every time someone suffers some sort of ischemia, including stable angina, it is possible that an arrhythmia is a result, which is why beta blockers are the mainstay of treatment for chronic and acute coronary artery disease. After 4 hours of ischemia, up to the end of the first day, it is irreversible necrosis, and the type of necrosis the heart undergoes is coagulative. Architecture is maintained, but the blue stuff disappears. That is the nucleus and the ribosomes, organelles. If you were to do electron microscopy, by the way, in the sample of that less than 4 hours, you'd see blebbing. But you can't see that on light microscopy, and the person's already dead, so you're probably not going to do EM. But now you're going to see coagulative necrosis. The earliest sign of coagulative necrosis is wavy myocytes. Literally wavy. They still have all their blue stuff, but you know that if the slide you're looking at is from a dead person, and you know though that if those wavy myocytes were on their way to full-on coagulative necrosis. If you lose all the blue stuff and cardiac myocytes are already red, eosinophilic, you're going to get an intense eosinophilia and loss of nuclei and organelles. Myocardium is already red, but if it loses the blue stuff, the nucleus and ribosomes, it's going to get even more red. The infarct in the first 24 hours gets deeply red, and the complications continues to be arrhythmias. Until all of the myocytes are dead, anyone can undergo depolarization, ectopy, circuits. As they die progressively backwards, the myocytes here die last,